Good morning and welcome to a very different type of medical grand rounds. We're going to continue medical grand rounds virtually, and what we're going to do is every week update the audience on what we're learning over the past week about the COVID-19 outbreak, not just locally but around the country. Try to share with you some of the science that's being learned, share with you some of the public health learnings, and try to keep the dialogue going so that we can both be informed, but also so that we can help keep ourselves as well as our patients and broader community safe. I'm going to turn it over to Errol for a moment. Errol Osdalger is Associate Professor of Medicine, Hospital Medicine faculty, and our Director of Medical Communications.
Yes, so our plan is we are recording this video, and with the approval of our presenters, we'll try to make that available to all of you as soon as possible today.
Thanks, Errol. So again, thank you to our presenters, and I want to introduce Dr. Stan Dudzinski. Stan is our first speaker. Stan is a professor of medicine in the divisions of ID. He's also the director of our Stanford Microbial Stewardship. Following Stan will be Dr. Ben Pinsky. Ben is an associate professor of pathology and medicine and the director of the clinical virology lab here at Stanford. Next up is Dr. Dan Shin, who is infectious disease specialist in Mountain View and has a lot of recent experience with the virus in his clinical practice, and he'll talk to us about some of the clinical issues. Next will be Dr. Sam Shin, who is a professor of emergency medicine and really the clinical director of emergency medicine services here at Stanford. And finally, we'll have remarks by Dr. Lucy Tompkins, a professor of medicine and our director of infection control at Stanford Medicine. And I want to thank all my colleagues for taking time to do this quickly, and then we'll open it up for questions.
Thanks. We're going to try to get through the presentations quickly so we spend a lot of time on the questions. I'm going to give a very brief bit of background information, and then I'm going to sort of jump forward to treatment options before we hear from the others, and then we'll hear from the others. So the topic of this Grand Rounds is COVID-19. That's the disease, coronavirus infectious disease 19. The name of the virus, just to settle things out if you read about it, is SARS-CoV-2. It has that name because it is very closely related to the original SARS virus, as you see from this diagram. It's an RNA virus, like SARS, originated in bats. They use the same host cell receptor, which is angiotensin converting enzyme 2. And of note is that the gene for the RNA-directed RNA polymerase of the two has 96% identity, which provides a potential therapeutic target for all of us. This is from yesterday. This is actually the Johns Hopkins site with the dashboard, and basically you can see that we have just about reached 1,000 cases in the United States. That the numbers of cases in China have slowed down dramatically, but the rest of the world is starting to catch up. This is Santa Clara County as of 2 days ago, 43 total cases, median age 58 years. At that time, 21 of those 43 were hospitalized, 10 of whom were in intensive care, several of them at El Camino Hospital. Unfortunately, we have Dan here to tell us about their experience. There had been one death to that point. As I said, I wanted to jump ahead to the therapies because we have chosen one of these for investigation. A variety of drugs have been suggested. I'll talk about remdesivir, chloroquine, or hydroxychloroquine. Hydroxychloroquine is widely used in patients with rheumatoid arthritis, and there's been known for 50 years that it has nonspecific viral effects. Several HIV protease inhibitors in the hope that there would be sufficient inhibition of one of the proteases of the coronavirus to work, and other drugs. And then I just want to mention among the immunomodulators, one of them seems, one that's been listed as IVIG, and of course, no one there is no, I'm sure, in the pooled plasma that's being used to to create IVIG, there's no antibody to IVIG. So this would be, the use of this might be totally based on a hope that there was some immunomodulatory activity. Another is tocilizumab, which is a monoclonal antibody directed at interleukin-6. It's used, for instance, in the pulmonary adverse reactions that are sometimes seen in patients with cytotoxic T-cell reactions, and it's been recommended for possible use by the Chinese. But let me just talk about remdesivir. And the reason, so this is a nucleotide analog. It's actually a prodrug. It was studied in Ebola in the clinical trials, but it failed versus 2 monoclonal antibodies that were eventually approved for treatment of Ebola. And as I said, it has close sequence identity in its RNA-dependent RNA polymerase between SARS and SARS-CoV-2. And it is active in animal models of SARS-CoV and also MERS-CoV, which of course is the Middle East respiratory syndrome virus, in which camels are thought to be the source. We are obtaining this drug for expanded access use currently, and we are about to become part of the Gilead, which is the pharmaceutical company down the road that has this drug, of their clinical trials. So this is, for now, our preferred agent. We've looked into others, such as interferon lambda, et cetera, but this is the drug that we will be recommending and hopefully enrolling patients in the clinical trial. So I'm going to end there, and Ben is going to tell us about laboratory testing.
All right, my name is Ben Pinsky. I'm going to be talking briefly about the diagnostic testing that we've brought in here at Stanford. So the first thing I just want to remind people is that we have a standard respiratory virus panel. This detects the seasonal coronaviruses, so please do not get confused. We've had some confusion regarding this. This assay detects only these seasonal ones, OC43, NL63, 229E, and HKU1. This alphabet and numeric soup of viruses. And the comment, although I know most folks don't read this in EPIC, says it does not detect the novel coronavirus, nor does it detect SARS or MERS. So just keep that in mind when you see the results from that particular test. So we brought in real-time RT-PCR for the novel coronavirus. This assay is based on assays developed by the Drosten Group in Berlin, Germany, and they published those very early on the WHO site and then in Eurosurveillance, and the reference is right there. These are 2 reactions that target both the envelope and RNA-dependent RNA polymerase gene, as Stan was just talking about. So we use the E assay to screen, and then for all positives, we run the RDRP assay. So if you see a positive result, it means that we've tested and detected 2 different viral sequences in that particular specimen. And important to note, this detects the novel virus as well as SARS-related coronaviruses. This is a subgenus level detection, but since the other viruses are not circulating, the viruses we are detecting are all SARS-CoV-2. And we have confirmed a number of these cases by sequencing. And the sequences match 100% to the current circulating strain. The performance characteristics of this assay are very sensitive and very specific. We did analytical sensitivity experiments, and in addition, the specificity was excellent. We have tested a number of the of the circulating seasonal coronaviruses, they do not react, as well as all other respiratory viruses, they do not react. And we've actually tested hundreds of negative samples as well. So very good performance for this that matches the performance of what has been seen by Corman and others. All right, so our current state of testing. On February 29th, the FDA reduced and relaxed the requirements for clinical laboratories to offer testing as laboratory-developed tests. And then we immediately completed the requirements for FDA testing. We received permission from the FDA on that Monday and went live with testing here on the 4th, so a week ago. As a requirement of this, we need to submit the paperwork for emergency use authorization within 15 days, so that is in process. The first 5 positive and 5 negative samples will be sent to public health for confirmation. We're planning to do that this week. And then, importantly, we initially validated nasopharyngeal and oropharyngeal samples. We subsequently validated bronchoalveolar lavage fluid, lower tract specimens, and then we're validating plasma. There's been a number of requests to screen our blood supply as well as screen plasma from deceased donors. So we'll see if we can get that going. These are some of the instruments that we're using. So we're attempting to scale up and automate. We're using as many of our extractors and real-time PCR instruments as possible in the laboratory. And at present, we're able to test around 300 samples per day. And that number is increasing, and we're hoping to get to 1,000 samples per day by sometime next week. So this is a rapidly changing situation, but our capacity is growing. I also want to point out that we are the reference clinical laboratory testing for the Bay Area. We're supporting testing for Stanford, for Packard, as well as Valley Care, as well as a number of external facilities, including UCSF, all of Kaiser Northern California, El Camino, which we'll hear about a little bit next, and others are coming online daily. So we're really trying to ramp up to support testing in the Bay Area and help out our public health colleagues to keep up with demand for testing. Here's the laboratory. We're off-site, so there's a little bit of delay in getting the samples over there, but our turnaround times are actually quite rapid. We're getting most samples results back within 12 hours and all within 24. So.
Hello, everyone. I wanted to share the perspective of what we're seeing at the front lines. Emergency department being the literal front door to the hospital, I wanted to share the perspective of what we're seeing, what we're doing to put systems in place to appropriately screen patients, and then touch a little bit on what the hospital is doing in response to increasing numbers of the PUIs and COVID-positive patients. Our strategy for the emergency department is to try to avoid utilizing the rate-limiting step in our department, which is the negative pressure rooms. Under the current guidelines for respiratory isolation, airborne precautions, we have a limited number of negative pressure rooms. We have 4 in the 500P and 2 in 300P, the pediatric ED. We've since split. And so our strategy is try to minimize the use of those to those who truly, truly need it. And to do so, we've moved up the screening process much more proximal in the process. In the current state, if you showed up with influenza-like illness, you'd be screened by the security person in front of the metal detector for fever, cough, shortness of breath, etc. Now we've actually moved a nurse out front by where the valet comes in, by the parking area, in full PPE to do the screening. We also have a physician in the lobby that we've had before for 16 hours a day. That's also the sole resource for that nurse to help screen. And the goal is that if you identify someone who's a PUI, you don't bring him into the lobby. You bring him around to our negative pressure rooms through the side. This quote-unquote drive-through model is something that we are putting in more formally actually this week. So in fact, later this morning, we are putting together a group from a disaster preparedness perspective to implement a model so that those that come in, we can rapidly screen. These are not the ones that are severely sick. If they're very sick, they automatically need to come into our department. But for those that meet the criteria, they can get rapidly swabbed, assessed, screened, swabbed, and then they can actually go home, where we will have a system to follow up. This model has been implemented elsewhere, other states. Rhode Island, I just saw an article yesterday that they were doing something similar. Other countries, South Korea. As part of this model, we took some lessons that we learned from 2009 H1N1 seasonal flu, where we simulated a model just like this, and it was actually published. And so we're taking some of the lessons from that, from other places, and putting that together. Once a patient makes it into our emergency department, if we run out of negative pressure rooms, we've been using closed doors with HEPA filters. And then what's been nice is that as we've now developed a process working with the Department of Medicine with the hospice team, those patients now go to a dedicated unit. And so the B1 unit is now dedicated for PUIs. And that ability to co-locate those patients has dramatically improved in terms of efficiencies, conservation of PPEs, and things like that. If patients are sick enough that they need ICU level of care, they would still go to an ICU because there are negative pressure rooms. The other aspect of the screening I want to touch on beyond the ED is what's happening in Express Care and OC Health. So these are the three entities that will be seeing oftentimes the ambulatory patients who have been exposed with symptoms. And so the Express Care has developed a model similar to, again, to the drive-through model that started this past Monday, where patients who are screened for potential PUI or potential COVID through a video visit will now have a sample swabbed in the parking area outside of the Hoover Pavilion. So on Monday, they did 11 samples, tested 11 patients. And so that model is happening 1 p.m. to 5 p.m., 7 days a week. The third component is OC Health. There's been a lot of challenges for OC Health. As you imagine, it's been completely overwhelmed by the amount of demand. And so that OC Health department has significantly been provided a lot of resources this week. So it's been scaling up to be able to meet the demand. But eventually, they will also be able to test patients as well based on a similar criteria. So again, the goal is that for healthcare workers. So the goal is that these are the 3 points that people can get tested, because we do want to increase the amount of testing. When we first started, we stuck to the very specific CDC criteria. So if you were exposed to a confirmed positive with fever or ILI symptoms, that's one criteria. Or if you travel from one of the 5 index countries, the tier 3 countries, with symptoms, and you required hospitalization, or you have no source of contact or infection, but you require hospitalization with fever and symptoms. Those are the 3 criteria that we currently have in place. We are likely going to be expanding that criteria this week, because prior to having the lab testing, it was restricted at the level of the county. But knowing that we have the ability to scale up the testing to 300 samples a day, eventually 1,000, we definitely want to test more people. And by broadening criteria, we'll be able to do so.
Good morning, everybody. I wanted to tell you how our hospital is developing all of these protocols in a brief presentation. First of all, we have activated essentially an emergency operations center. It's called the COST meeting. It doesn't have anything to do with cost, and don't ask me what COST stands for because I can't remember. But that meeting takes place every day. Norm Risk is the head of the committee, and we have an agenda to look at and to go through for an hour every single day. There are key people from the hospital administration and different services, as well as several physicians, clinicians, including infection control, emergency room, and Department of Medicine, and many other departments are at the COST meeting. The COST meeting is designed to bring forward to essentially to adopt certain suggestions and documents that have been brought forth from the previous day, and to say this is what's going to go onto the intranet. We're using the intranet as our source of truth. It's being updated daily, and it's really coming through the cost center. These are the group of people who have to essentially say, yes, this is how we're going to operate today. In the meantime, many people are given, in fact, everybody on that committee is given multiple assignments to work on, to develop another policy. How are we going to use occupational health? Obviously, the Director of Occupational Health is a key member of that committee. And then in addition to that, Sam Shin and Megan Mahoney have a larger group of clinicians who are also meeting every single day to discuss clinical issues. And they relate up to the cost meeting in the morning. And so we do have essentially an operations command center going. It's in the form of the cost committee and then all the working groups. We have two of our vice presidents in the hospital who are receiving all this information. I must say that virtually all of us who are on the cost committee are working about 20 hours a day. Sometimes I think Dr. Risk never gets to sleep. And so we're in constant communication with each other. And it's as Dan said, it's a fast-moving target. The signs are more subtle. So what I wanted to discuss this morning is what we expect from all of you, our providers, our healthcare workers. First of all, go onto the Santa Clara website and get information for the public, how to protect yourself. Social distancing has a lot more elements to it than the 6 feet. And I can't spend the time to describe all of those, but these are things that the kids are being taught. It's all over the media, and it's on the Santa Clara County Public Health Department's website. Questions, what should I do to keep myself safe? So obviously, we want you to keep yourselves safe because we need you to come and take care of our patients. And so we expect every person who comes to work in the entire enterprise to monitor themselves before they come to work. If you feel you have a fever or you take your temperature, and I hope every one of you has a thermometer, but they're hard to find these days, do not come to work. Do not come to work if you are febrile. But you must call in to the occupational health number. It's prominently displayed on the website, and they will screen you right then and there. And if necessary, testing can be performed if you're quite ill. But nonetheless, occupational health is the repository of this. The other thing we want you to do is to check in with your supervisor or your attending, if you're a house officer or a nurse and a supervisor, just to say, I am fine. So if we expect you to monitor yourself for fever or cough or shortness of breath or sore throat. Now, I know there's a whole lot of in between there, but those are the things that we'd like you to at least say, I don't have any of those. And once that's happened, if you have any of those other symptoms besides fever, then you really do need to notify OcHealth immediately. And if you have a fever, obviously they're going to tell you if you've already come in, you need to go home, and they will determine if COVID testing is indicated. You will know that. If you have a cough or shortness of breath or sore throat without a fever, and you've touched base with occupational health, you can continue to work wearing a surgical mask for your entire shift. You have to practice good hand hygiene, and wear gloves is our standard precaution, and obviously you have to change gloves every time you do hand hygiene and between patients. That's standard work. What to do if you are a person who has had an exposure to someone with COVID-19, I'm calling it COVID-19. And so again, as Stan said, that's someone who's defined as a healthcare provider who's had close contact within 6 feet for more than 2 minutes. This is CDC's guidance. is essentially just defined as a potential contact. However, we have decided if a patient's in an airborne room, which we still have a lot of them, and you are wearing all the proper PPE and you've seen the patient and done it all, you may continue to return to work. You do not need to contact OC Health. We are assuming you are safe. If you've, and so I think that's very important. The number for the fever is 100 or greater. But the idea is that if you have these other lower grade symptoms without a fever, you can continue to work with a surgical mask. You do not have to go into self-quarantine. And that includes people who live with a person who has documented COVID-19. And we've had a couple of instances already, and those people do not need to be quarantined, but they do have to self-monitor every single day, touch base with occupational health, and they can return to work. And I think that's really important to say, because we need people to come to work and to take care of our patients. Otherwise, we can't, follow our oaths to care for the sick and the needy. If you're asymptomatic, take your temperature before you start your shift or whenever, and notify your supervisor. Wear a mask if you have the other symptoms other than fever, if the healthcare worker is asymptomatic and you've been exposed to somebody, these are the same guidelines. That is, wear a mask when you come to work, self-monitor yourself, and immediately contact occupational health if you develop symptoms of any sort after you've had a known exposure. And so that's what a couple of our people who are living with someone who's already been diagnosed. So again, you don't necessarily have to go home for 14 days. As long as you are well, you are fine to work. And I think I could, in that instance, if you have any symptoms, you still have to be touch base with occupational health. They'll tell you to wear a surgical mask.
And that is, you're making the assumption that asymptomatic transmission doesn't occur.
Yes, we are.
And actually, go ahead, Stan.
Yeah, go ahead. Yeah, but it, of course, has reported to have occurred.
Yes. Stan, we had to make some assumptions, and that's essentially the guidance from the CDC. Yes, there probably is asymptomatic transmission, but we simply can't work if we're just worried about asymptomatic transmission. And so we can't test everyone who's asymptomatic. That's clear. Not all of our healthcare workers can be tested just because they're asymptomatic. And so, yes, we might miss somebody who's asymptomatic, but this is the only way we can analyze this.
I want to make one comment too about dual infections. I think that's that we do see dual virus infections in the general population. The Chinese reported that among their COVID cases, it was only seen in 2%, but it wasn't clear exactly how much they screened. Now, one thing we do know, though, is that in our severely immunocompromised population, particularly hematopoietic stem cell patients, we not uncommonly see more than one virus come up on their panels. So I personally wouldn't use that criteria for at least that group of patients. I would proceed with the testing. There's very little data out there on immunocompromised patients at all. The people in Washington are starting a registry because they have one case, and I don't know that there are any other people
So
in that
the
registry
issue around
yet.
testing asymptomatics exposed people is that you don't have a guarantee that tomorrow that patient won't then be shedding. So Marissa Holobar and Lucy Tompkins and I have spent many hours talking about this, and we agree there may be a low risk of asymptomatic transmission, but just a negative test today doesn't mean that you have a negative test tomorrow. We haven't seen evidence of that happening yet, and unless we have evidence to the other contrary or CDC tells us to do that, at this point, that would mean you'd have to test somebody every day for 14 days, and we're not quite ready to do that yet unless we get guidance from the federal or other public health authorities.
So I say we are currently screening for both. So if you're concerned about COVID, you are getting the full respiratory panel. And our protocol in the ED is that you don't wait and for the flu A or B or RSV looking for alternative diagnosis. If you're concerned enough, you get both at the same time. And even if the flu A comes back positive, you still maintain the same precautions as if you were potentially taking care of a COVID patient. And that occurs as we admit the patient from the ED to the inpatient as well.
And our N is quite low. However, we have had one co-infection so far with rhinovirus, which is not particularly surprising.
I want to thank the panelists. Currently, and so first off, I want to thank everybody for not showing up today. We currently have over 1,000 people on the Zoom chat. We have amazing grand rounds all the time, and we never get this level of interest in our topics. The last time we had this level of excitement for grand rounds was about 10 years ago during the swine flu epidemic. No surprise. What's unique about this time is during the swine flu epidemic, everybody was in the same auditorium, packed in. We couldn't even get people in there. I see Norm's nodding his head, remembers that. So it's very unique, this scenario we're in right now. The recent topic we were just talking about, asymptomatic transmission, I think really hits home at kind of the theme we're getting as the most popular questions. And guys, we have over 90 questions right now. Usually we end grand rounds in about 5 to 10 minutes. We're obviously going to go over, but we're obviously not going to get to answer all the questions. So I'm going to try to get through as many as possible. The first one is really talking about and Sam talked about this a little bit, and so did Ben. What's our threshold for testing? So as there is more data coming from China and other places, that symptoms can be mild and don't have fever presentation. What is the threshold for testing now that is more widely available? Also, Steve Goodman asks a similar question. From Stanford website, it appears the only people who will be tested are those who are strongly symptomatic. But for the purpose of quarantine and prevention, can it be as important to be testing mildly symptomatic people who spread the disease to close contacts? When will Stanford be doing when will they expand local testing?
We are expanding local testing, and in fact, as much as our virology lab can accept. And so the suspicion index is going to continue to change, I believe. We use right now fever or cough or shortness of breath or sore throat. We know that there's lots of URIs out here, and that's why occupational health will be your first point of contact. They will assess just what are your symptoms? Is it just you've got some postnasal drip and you're congested? I believe they would tell you you can return to work wearing a surgical mask. But that's our point. And every day we will be updating occupational health. They're members of the cost committee. And there are representatives from Packard, I absolutely have to, and ValleyCare, who are on that committee. And so we're all hearing the same information. And we'll adjust the definitions as we need to for testing. So it'll eventually be, as Ben said, we can test 1,000 people total in the course of 24 hours.
Okay, thank you very much. David Sobel asks, how long after exposure can the current test for the virus be sensitive with or without any symptoms? What are the current testing recommendations for those with known exposure?
Again, it's occupational health that makes that decision. And I think I read the definition, but the intranet will have all that information. And also it'll have another section that says frequently asked questions. And that we're trying to update that every single day as well. I believe it's on the website right now on the intranet. So again, if I haven't made myself very clear, this information is on the internet, I believe, as of this morning, or it will be shortly after we have the cost meeting, what we're talking about right now.
Thank you, Lucy. I'd like to ask, Dr. Harrington asked me to bring up Dr. Mahoney, Megan Mahoney, to talk a little bit about the outpatient testing capabilities.
Okay, thank you. Yes, Hi, good morning. As Dr. Sam Shin alluded to, we are happy to roll out outpatient testing in the ambulatory setting at Express Care. We have a video visit service that assesses patients who have these symptoms, acute respiratory viral infection type symptoms. And when they are then deemed to meet the criteria for testing after that video visit, the patient is then scheduled for a drive-through specimen collection session. And we currently are open 1 to 5 every day of the week, but we hope to expand the hours and our capacity to conduct those tests very soon, in fact, as early as tomorrow or the next day. So currently we have the capacity to test around 30 or 40 tests, and we hope to broadly expand that very soon.
Thanks a lot, Megan.
If I can add that, because this question around how can we enhance testing comes up often. Again, in collaboration with your department, we really want to be consistent in terms of how we're testing the community and people who are showing up. And ideally, kind of from a system perspective, we want the sickest people to come to the ED to be tested, of course. And then the ones that aren't sick enough to be hospitalized, hopefully now we have the ability to have them be tested at Express Care. Though again, if someone walks to the ED and they don't need to be admitted, but yet they still meet the criteria to be tested, we do want to test them. And what you'll notice as of this week, when you see our emergency department, there's an area with multiple tents. It's not the big tent that we had a couple of years ago, but these are essentially smaller individual tents, again, for us to screen those that are well enough that we can discharge. And so hopefully in combination between Express Care, Occ Health, ED, we can capture a lot broader number of patients that we currently today would turn away and say, sorry, you don't meet the criteria, we will not test you in the ED today.
Thank you. I'm going to keep going with a couple more questions here first. See people raising their hands in the room. Based on our case uptake thus far in the immediate Santa Clara County, do we have estimations as for what we might expect the outbreak incidence curve and when we can expect that surge number of cases? So what can we expect as of now as far as the number of cases and when?
Lonnie, do you have any of that information?
Thank you.
Thank you. So we don't right now have information about surge. We're looking around the world and looking, as you all are as well, and seeing different patterns of disease. And we suspect that it has to do with the transmissibility of the pathogen and the ability to do what you're doing now, which is social distancing, so decreasing the amount of transmission. Some of you have heard Tony Fauci from NIH talk about flattening the epidemic curve. So what we probably saw in China was an explosive growth because it wasn't detected for several weeks to months beforehand. What happened in the U.S., probably because of quarantine, et cetera, in China and other places, and our restriction of travel, is that we're seeing a flattening of the epidemic in the U.S. So we probably will see more prolonged disease in the U.S., but it won't. We hope it won't get to that peak. We've also instituted testing, so our sense is that it won't be rapid, but it may actually reach a level where we will be able to build up our medical capacity to handle cases because it won't be as explosive. So, but we, again, don't know. We don't know when it's going to end. It's probably not going to be April, but we don't know exactly what's going to happen. And then the other question, of course, is whether it will be seasonal, whether will it be long-term, year-round, et cetera. Again, don't know the answer to those questions.
I just say that a lot of people have done modeling, and there's various in different countries, and there's very wide ranges. Today, though, that Angela Merkel indicated that they believe that that eventually 70% of the German population will be infected, and Germany is not a hotbed of COVID-19 right now. So, but I don't know the data behind that.
Thanks, Stan. We'll jump over to this question that kind of goes along with it. Since the U.S. hasn't been testing systematically, how reliable is the curve of spread?
No answer.
Testing.
So I think the take-home message is tough to know right now because we don't have the data.
It hasn't been enough testing. That's the problem.
Okay, thank you. Why don't we take one question from the room here? See someone over. Do you want to come on up and ask?
Yeah, hi, I speak loud enough.
But you need to have a mic for Zoom.
I'm going to hold it with this. Hi, I'm Jeff Crook, internal medicine, Palo Alto. Thank you all so very much. Truly appreciate it. Everybody's working hard on this. I do still hear a mixed message, even from our panel on testing, where Dr. Shin was very clear that they are eliminating people and sticking to some pretty firm criteria. However, I think that the public and even a lot of community physicians are seeking to test more widely. And I'm hearing the ER doctor tell us we're going to roll this out. The virology specialist telling us it's ramping up. Can you give a little more clarity to what you see evolving in the next few days, potentially for community physicians who very much want to be on the front line with you, doing testing if possible, if we have the gear, many don't, to try and be able to get samples to you and get our patients aware, even if they are sore throat. Thanks.
I'll start with just clarifying. What I described in terms of our criteria is sticking to the CDC and Santa Clara County's guidelines. We obviously wanted to be consistent, just because there was limited testing capabilities.
Mike.
We wanted to be consistent with CDC and Santa Clara guidelines. As of today, we are actually going to be rolling out new criteria. Our rate-limiting step, again, even with the county testing 30 samples a day, our main rate-limiting step was for the ED, because we're seeing obviously a lot of other patients. It's really the physical plant, the infrastructure to support all the testing of patients that need to be under negative pressure, full PPE, airborne precautions. And so we wanted to reserve that capacity for people who are very, very sick. Having said that, if someone walks in today or even a week ago and they didn't need to be hospitalized, but they met criteria because they were symptomatic, and they've been exposed, we obviously would test all those patients as well. The patients we would like to have be done in an outpatient setting, which is why it's been great to have Express Care then create that capacity, is the patients who are very well. They're doing well. They don't need to be hospitalized. But they certainly should be tested because they're symptomatic. The difference between, I would say, last week and this week, what we're rolling out, is that we're going to loosen the criteria much broader than what CDC has set out. And so the geography, for example, is not as strict of a criteria. The exposure to a confirmed COVID positive is not a criteria. And so we can eventually try to test more symptomatic patients. It's just that we'd love to have the have those patients be tested, be distributed, so that if you're well, you can be tested at the Express Care setting. But if you're sick, then by all means, come to the ED and we will test you.
So, Jeff, as I understand it, though, your real question is, what should the community physicians be doing? How would they get into our network? So we're trying to protect and deal with our own patient population, our own people who come to our clinics, people who come to our emergency room. But I don't know the answer to that, and I think if Norm's still here, then that should be a very hot topic on our agenda for cost, because I don't know the answer unless you do, Norm.
I think we all want to broaden the testing to allow community physicians to do it as well. I think it'd probably be useful to have universal standards for whom we're testing, and I do believe it'll move to influenza-like symptoms without any other history, probably after or with other respiratory tract pathogen screening at the same time. Right now, we're providing, as Ben said, a lot of screening for other hospitals. Some of those are only providing screening for inpatients. For example, I know that's the case at UCSF. And they have some healthcare workers who are symptomatic, who are outpatients, who can't get screened. So I think we need to prioritize healthcare workers in particular that are symptomatic at other places. That would be my next priority, just so that we're maintaining a healthcare workforce across the Bay Area that can do this. But I think eventually it will move to all influenza-like illnesses, and that will probably be pretty fast. The other area we've talked about is high-risk populations. So Andra Bloomcombs and others are interested in screening people in nursing homes because of the experience in Seattle. So I think we should pick off deliberately high-risk populations and healthcare workers as highest priority, and then extend it further as we have more capacity.
It's my understanding, though, that really by next week, it's basically unavailable. There's no problem with running the tests. You'll be able to run presumably all the tests that come in. And the real drawback are the mechanics of getting the sample. And that all depends on and that's all the result of the CDC still requiring airborne isolation, which we have been hearing for more than maybe 2 weeks that they're going to change, but they haven't. Today they did do one thing. Because of the shortage of equipment, it's now okay for healthcare workers to wear surgical masks instead of N95 respirators, but I'm told that we have an impending shortage of surgical masks as well.
So I would say the other thing they've changed, is that now in terms of collection of the specimen can be collected in a non-negative air pressure room by a person wearing full PPE, and therefore we can get that information out. That'll be on the internet as well. And so you might think of, Jeff, how you could do that in your clinic. The question will be, how do you get the specimens over to Stanford, or whether we can accept your specimens? That's the real issue for the community. And at some point, you know what? I'm not sure we'll be able to test everybody with whose symptoms, because we don't have a treatment. Honestly, it's really going to have to be that we're going to have to take care of the people who really need hospitalization, is my guess. Ultimately, if this goes the way some people project. I mean, it's a pretty scary story, but we don't know what proportion of the population will be ill, and what can you tell the patient except your usual guidance, and you may be flooded with calls every day to say, well, now I have this, or now I have that, and I think the trigger is ultimately going to be, does this person really need to be seen in our emergency department? That's what I'm guessing, and it'll be up to each individual provider to make those decisions. We're taking care of our own clinic patients through Express Care, and our own healthcare workers through our own institution. But what's coming down the pike for all of us, and we're all community dwellers as well. That's why I really wanted everybody to say, you have an obligation to yourself and to your family to protect yourself. I'm not traveling on commercial aircraft, even though they're doing their very best to keep them clean. They have HEPA-filtered air and so forth. If you're sitting next to somebody who has this virus, your chances are pretty good. So I'm avoiding large groups, and I think it's great that Bob has made the decision that this is going to be a virtual Grand Rounds. We have a mission of learning and teaching and information that we must continue here. Our university is not closing, our medical school, our hospital will never close. And so we need to continue to have everybody be able to work.
Thanks a lot, Lucy. I'm going to change tones just for maybe a quick question here, a couple of them with the same theme. How long can the virus stay alive without a human host? And someone asked, can it stay alive on things like vegetables? And if you eat it, is it dangerous?
Oh, no, but it is important to point out that this virus does last on surfaces for several days. And so that's why the contact precautions, that is washing your hands, disinfecting, surfaces, doorknobs, your microwave at home. I use a towel to open the doors, paper towel to open the doors around here. So I don't have to touch the common such surfaces in the hospital, and same thing at home. And so that is an important part of coronaviruses in general, is that they can last in the environment on surfaces. Now, about eating, as far as I know, there's no evidence that you can acquire the infection by eating food.
What about eating out at restaurants, coffee shops, et cetera?
I'm taking my family out to dinner on Saturday. I don't think the people at the next table, nobody in my family who's ill is coming to dinner. And so I don't think the people at the next table, they'll be farther than 6 feet away. I wouldn't go to a bar.
Okay, fair enough. Another question here. I understand that data in pregnant women are currently limited. But what about the prognosis for women who are expecting? Should they do anything over the course of the 9 months during this outbreak?
Avoid being infected. The data is limited in pregnancy so far. The very limited data suggests that there's no increased risk of severity of illness as there has been, for instance, with influenza virus.
So we've looked at data, published and unpublished data from China, and quite a number of women pregnant have been infected with no untoward symptoms so far, and their infants appear. There is evidence of potential vertical transmission, probably postpartum, but those children have all done well.
That's one of the mysteries, is why the children are less commonly infected and why they all seem to do well. I don't think anybody has any good understanding of that.
How many ventilated patients can we simultaneously care for at Stanford? How likely is that this capacity will be overwhelmed? It's been a big question. I'm going to give the mic to Norm. Best person probably to answer that anywhere.
Right now we have about 80 staffed beds and ventilators to support them. We've been doing an inventory of our ventilators to make certain that we could provide those services. In the United States, there are about 46,000 ICU beds across the country. I think the disturbing part is lessons we're learning from Lombardy in Italy and other areas where there are more patients than their ICUs can manage. And there's been some modeling of this as well. You know, if we were unlucky enough to have the penetration that we had in the 1968 influenza pandemic, we would need about 200,000 ventilators. And we only have 46,000 ICU beds. And if it were similar to the 1917-18 pandemic, which I think none of us believe it will get that bad, we'd need 3 million ventilators. You know, everyone is circumspect about the outcomes as well in ARDS in this disease. The reports from China make it look as if it has a higher mortality than other causes of ARDS. And another area that there's not much data on, just some sporadic reports, is ECMO in China, which is obviously very resource intensive, but almost all of the patients died on ECMO that were put on ECMO in China, and that is different from our experience with influenza A as well, which has about a 50 or 60% survival rate in ARDS that can't be supported otherwise. So there's some evidence that if you get to that level of severe respiratory failure, the prognosis is bad. In the Lancet paper, it just came out, there were 33 ventilated patients, 32 of them died, which is far more mortal than our experience with other causes of ARDS.
Thank you, Norm. And we'll get to a couple more questions here. Wuhan underwent complete lockdown at some 500 infections and a dozen deaths, yet their cases continue to skyrocket in the next couple of weeks. Are we past that point, and are we doing enough? Tough question to answer. In Wuhan. So the question was, it seems like they put people on lockdown, and we know that they went pretty extreme to put people on lockdown, and yet cases went up. Are we past that point? Are we going to have, no matter what we do, I guess, what the question is, are we going to have extreme spread?
I don't think anybody knows. I think, as Bonnie said, Dr. Tony Fauci, feels that we can flatten the curve, which means if we use all the social distancing and everything else, that we can flatten the curve. It won't be like the explosive outbreak in Wuhan, because we've had a fair amount of advance notice, and we are, all the hospitals and organizations are planning something like COST, if they don't call it incident command. And so flattening it out means it'll last longer, but fewer people will become infected. And we certainly won't see, I don't think we'll ever see the scenes of, building new hospitals to accommodate patients. The other thing about China is they don't have they don't have primary care. They have nothing between, the drugs, the pharmacist and the hospital. So they have a completely different healthcare system, which is obviously completely inadequate. We have primary care. We have physicians in the community, to manage patients, and so I think that's not going to be. We're not going to be anything like China. What we're going to be like, I don't know.
Thanks, Lucy. I'm going to ask one more question. I think it's a very important one here from Mira Shefferin. Should we be advising older adults to stay at home from adult daycare centers for older adults with dementia? They're clearly vulnerable, but the county health departments have not closed them, and they provide meals and needed care.
I think our county, Sarah Cody, the healthcare director for Santa Clara County, has been more aggressive than other counties have, and she's already, indicated closing large events, and I eventually think they will announce that same thing, same advice.
I mean, I think the whole point is that every contact with another human being increases your risk very, very tiny amount. In data looking at exposures in the United States, the transmission rate to close contacts, symptomatic transmission rate, so this misses the asymptomatic transmissions, is 0.45%. Transmissions to household contacts was 10.5%. So it's a matter of coming into contact with someone and the amount of time and intimacy of that contact. It's obvious. I mean, it's just probabilistic theory. So so those people are at increased risk, and they happen to be a group of people who are at increased risk of dying. And to the extent that care can be found for them, because it might not be possible for those families to bring those elderly people back home during those days. Somebody has to put food on the table. Everybody has to deal with that individually. And if the county decides at some point that the risk is too great, then everybody will have to deal with it.
Thanks, Stan, and thanks to everybody. I want to apologize to all the questions we still have pending that we won't get to today. We have over 100 questions. There clearly is an ongoing need to address these questions, and Bob and I were just talking about coming up with different ways to continually keep this discussion open, because, of course, it's a dynamic dialogue. So please reach out to us and let us know what thoughts you have as far as communication. We will look at connecting with our experts to continue ongoing webinars that we can keep this discussion going and keep everybody up to date. Dr. Harrington wanted to leave you with a few comments.
So first off, thank you to my colleagues who volunteered to come out and share your expertise this morning. I think this has been invaluable. Thanks to the 1,000+ people online for tuning in. We're going to be posting this in a couple of hours on the department YouTube channel. For those of you who are on our email address, we will make sure that an announcement goes out today that that's available. And we will be spending some time in the next few days planning the next several weeks of Grand Rounds, which will take place virtually with the focus on COVID-19. So again, thank you for viewing. Thank you, Errol, for setting it up. And thank you to the panelists.